Hi, this is Brian Kim. I'm going to share with you case number 133 in the best way to do cataract surgery series. This is a 3+ dense lens, and you're going to see double chop, cross chop, mechanical fracturing techniques. And all of this is to reduce ultrasonic energy, reduce complications. And in my experience, when you do these maneuvers and follow these principles, also you can have clearer corneas postoperatively, better patient experience, and of course, less damage to the eye. So this is the eye. You can see I'm using a corneal marker, which will help me to center and size the rhexis. And then using the cotton tip, I'm turning the eye to the left. And then this allows me to use my paracentesis blade and make an incision flat to the iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is intracameral lidocaine and then some intracameral epinephrine. And this is some dispersive viscoelastic to coat the corneal endothelium and flatten the anterior capsule. And this is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, and then enter. I'm pushing some more viscoelastic in. And this is the puncture style rhexis. Again, these are older cases that I'm posting here, but I'm able to puncture the center. And you can see that they're older cases because of my capsulorhexis forceps. I don't use these forceps anymore. So I puncture the center and then grabbing the right side of the tear, going around circumferentially. Again, trying to stay within the confines of my mark that I made, which will allow me to achieve a well-centered and sized rhexis. Burp some viscoelastic out, and this is the capsulorhexis hydrodissection technique. I place a cannula under the rhexis edge, contra-incisionally, point the tip down, get a nice wave, come up, decompress on the left side, and then hooking the peripheral lens on the right, and you can see the lens begins to spin quite easily there. Irrigating the surface of the eye, adjusting my sleeve, lifting the incision with the chopper, going in with irrigation off to minimize Descemet's trauma, removing the surface epinuclear material, placing the chopper under the rhexis edge contra-incisionally, pointing the phaco tip vertically subincisionally, crushing and bisecting the lens in half, that is double chop, spreading and making sure they're completely apart, placing the chopper around the right heminucleus, hooking it and pulling it towards the phaco tip, crushing and bisecting the right heminucleus, and that is cross chop. Using some vacuum to lift that first quadrant up, getting it around it with the chopper, crushing it between the instruments, and then I'm able to emulsify the lens pieces. Placing the chopper around the second quadrant, hooking it, and then crushing it between the instruments. Actually, for some reason I stopped there, so I'm going to go ahead and turn it, placing the chopper around the second heminucleus, pulling it centrally towards the phaco tip, crushing and dividing the lens there, placing the chopper around that quadrant again, crushing it between the instruments in another cross chop maneuver, and then lifting that piece up with some vacuum, crushing it between the instruments into smaller and smaller pieces, and then emulsifying the lens piece. Turning the lens pieces in front of me again, placing the chopper around the lens piece, pulling it centrally toward the phaco tip, crushing and dividing the lens into smaller pieces, performing the same maneuver again, crushing the lens piece between the instruments, using some vacuum to grab some of the remnants, and then emulsifying those pieces. It doesn't seem to want to come up with the vacuum, so I'm going to go ahead and crush it again, bisecting the pieces again, and then now that piece is loose and it comes up. And so that's another thing. When you use mechanical forces, it does really loosen up the pieces a lot easier so that you can pull the pieces up out of the bag. Placing the chopper around that piece again, crushing the lens between the instruments, crushing the small remnant pieces, and then emulsifying the lens pieces. Using some vacuum to lift that piece up, crushing the piece with the instruments, and then emulsifying the lens pieces. There's another loose piece, crushing the pieces between the instruments and then emulsifying the lens piece. So now all the endonucleus is removed. I grab the anterior aspect of the epinucleus, which starts to tumble out slowly. I'm keeping the chopper deep, trying to protect the posterior capsule from the phaco-tip. Pulsing with my foot pedal with the vacuum. So I take the chopper out, push BSS in, take the phaco-tip out, go in with the INA handpiece. I always start subincisionally, peeling the cortex from anterior to posterior in the subincisional area first. And doing the same thing, going around circumferentially, peeling from anterior to posterior. And if I don't grab the anterior aspect, I just reflux. I press the reflux button, release the material, and then go ahead and grab the anterior aspect. It's just better to do it that way, because if you grab the posterior, then you're going to have these fine wispy lens material you have to go after anyway. It's not as clean of a polish and removal of the cortex. So you switch to polish mode, and I'm polishing underneath the rhexis edge, removing all the lens epithelial cells in front of me. You can see I grab the bag there, and that just goes to show the patient does have some zonular laxity. It does that little puckering up. I call that the spider sign, when it puckers up the posterior capsule that way. But thankfully the polymer tip is very, very good. And even though I do that, it doesn't cause any problems or damage to the posterior capsule. And the reason I'm doing that, I'm not trying to do the spider sign on purpose, but there's some fine adherent material on the posterior capsule. I was trying to remove that material. Every time I did that, though, it puckered up the posterior capsule. Go ahead and polish in the subincisional area with a cannula on BSS. That looked clean, and then I'm filling the bag with cohesive viscoelastic. And then I'm going to go ahead and polish under the rhexis edge, first on the left side, and then on the right side. So you can see this is the old sweeper. Look how short it is. Look at the angle. It's not angled. And you can see it doesn't have that kind of a sharp tip on this top edge of this sweep. It's very dull. So widen the incision with the blade, and I'm going in with a 3-piece lens. Again, with these dense lenses, I always make the assumption that the bag is a little bit loose, and my assumption was confirmed. As you saw, I was trying to polish the posterior capsule, and it would pucker up, causing that spider sign effect, which again is a sign of loose zonules. So I go ahead and place the 3-piece lens into the capsular bag. I'm pointing the bevel to the left, and make sure the leading haptic is going into the bag. Make sure the optic comes out planar, and then I'm using the Maltzman to dial the trailing haptic into the bag. So I go in with irrigation off, activate irrigation, and very carefully I go underneath the lens, removing the viscoelastic from within the bag, very carefully here, making sure I watch the iris. Since I widen the incision, I do not have very good chamber control here. Removing the viscoelastic from the anterior chamber, very carefully making sure when I come out that the iris doesn't come forward, and then I hydrate my incision. So again, this is a 3-piece dense lens. You saw double chop, cross chop, mechanical fracturing techniques and principles. Again, using crushing forces between the two instruments rather than going after lens pieces with high vacuum, rather than having to use sculpting, cracking, holding the lens with purchase, all the traditional techniques we've learned. I'm just simply using crushing forces, maneuvering my phaco-tip and chopper around the lens piece, crushing the lens pieces into smaller pieces. This is a very zonule safe technique because all the forces are directed towards the center. Again, I'm using crushing forces, which means reduced ultrasonic energy, and I'm able to have clearer corneas, less risk for complications, less use of vacuum, and so forth. And so as a result, I feel like this is the best way to do cataract surgery, in particular for the dense lens and with weak zonules. So I hope this was helpful to you, and I thank you for your attention.